And gentlemen, thank you so much for joining us today. We will be talking about the psychological and psychosocial effects of wounds. My name is Flora Coker, and I'm the founder of Encapsulate Healthcare Solutions. And for those of you who are new, the organization was formed to be able to equip healthcare professionals in the area of wound management to improve their skills. As healthcare professionals, we always have to continuously develop. So that's one of the aims of Encapsulate Healthcare Solutions. We also do programs for the general public to enlighten them, empower them, and inform them on health topics so that they're always armed with the right information regarding different health issues. So once again, thank you for joining us today. If there's someone you know who should be here, who's not here yet, give them a reminder for them to join us. But I wouldn't want to take a lot of our time, so I am going to introduce our first speaker straight away. And our first speaker today is Professor Olufemi Fasomade. He was appointed a consultant endocrinologist in 1997. He's also a professor at the College of Medicine, University of Lagos. He's the unit head of Endocrinology, Diabetes and Metabolism Division in LUTH. And he has just completed a 4-year tenure as the chairman of the Medical Advisory Committee of LUTH. Currently, he's the chief clinical coordinator of the NSIA LUTH Cancer Center. He's also the president of the Endocrine and Metabolism Society of Nigeria. He has authored and co-authored 5 books and has over 120 publications in peer-reviewed journals and more than 300 abstracts and posters presented locally and internationally. Honestly, we are really privileged to have him today to speak to us on this topic of psychological effects and psychosocial effects of wounds. So, Professor Fasomade, the floor is yours. Over to you.
Thank you very much, Flora, for having me on your program today.
Please, could you mute yourself if you're not speaking?
I will share my slides now and then go straight into the talk for today.
Thank you.
Yes. Share. Okay. Let me go to slideshow. Okay, good. So today I'll be talking about healing the wounds. And I guess the reason why I was chosen to speak first is because quite a number of the patients that I manage in the 2 sections I do work in happen to have wounds. And these wounds are quite distressing and take some tax to heal. I'm an endocrinologist, so quite a number of the patients I see have diabetes, and quite a number of them are hospitalized because of wounds. I also work in the cancer center, so there also we have a lot of patients who have wounds from different cancers, but I'll be using the diabetes platform more to talk about how wounds are healed. So this is my outline. I will be talking about what wounds are and the conditions that lead to chronic wounds or ulcers. And then I'll spend more time with diabetes foot ulcers and the different types of diabetes foot ulcers, and then how to prevent diabetes foot ulcers, and then finally how to promote the foot ulcers. If you have any questions during the course of our presentation, please keep the questions to the end or put them at the chat box, and at the end, I'll be able to answer them so that we can have a free flow of the presentations for today. I will not be the only person speaking. Others will also be talking about other aspects of wounds. So the first question is, what is a wound? What is a wound? Very often people wonder. It looks simple, but a wound is actually any injury to a living tissue which is caused by a cut, or by a blow, or by other impacts, especially one in which the skin is damaged or broken. And an ulcer is caused by an underlying disease or other reason. So if you inflict an injury from outside, we call it a wound. If the wound occurs from an internal process such as diabetes, we call it an ulcer. Or if you have a stomach ulcer, we don't call it stomach wound because the process that led to that wound is from within. So we call that one an ulcer. But otherwise, both of them are similar in the sense that they are removal of this surface or the epithelial lining, which leaves the tissues underneath exposed. So very often we use wounds and ulcers interchangeably, especially to lay audience. So there are several medical conditions that can cause ulcers. And remember, I said ulcers are things that are due to conditions that are underlying. And a common one is diabetes mellitus. Quite a number of people with diabetes will have an ulcer within the course of their ailment. Some people will put it at 15 or 25% of the people with diabetes will at one time or another have a chronic ulcer. So diabetes mellitus is a major condition. Others are Hansen's disease. Hansen's disease is leprosy, but we try to use a more humane name, which is Hansen's disease, to describe the condition. It also causes ulcers, and that is why if these ulcers are not properly managed, you could actually lose fingers or toes to Hansen's disease. Other medical conditions that cause ulcers are varicose veins. Varicose veins are those worm-like things that you see at the back of the legs of people who usually are either obese or people who are pregnant. We call them varicose veins. And usually at the bottom of the foot, around the ankle, if you have a lot of varicose veins, it could lead to darkening of the skin, breakage of the skin, and that's what is called a venous stasis ulcer, meaning that an ulcer secondary to varicose veins. In other people who have ulcers, this is more common in children, people that have some atopy or that have allergy, and this can cause ulcers. So you have such in the cheeks or the feet of children. So we call it eczema or dermatitis or atopic dermatitis. This is another condition that causes ulcers in the people that have it, and the ulcers appear spontaneously. But all the four conditions I've listed here, the ulcers that they do cause, they usually take quite some time to heal, ranging from weeks to months, depending on how they are managed. In diabetes, the foot ulcer could be as simple as what we have here, which is, you can see a big ulcer under the toe, and then you could see some other areas that are pre-ulcer formation under the ball of the forefoot. So this is what a typical diabetes foot ulcer looks like, and this is one that is not so complicated. But a person who has this type of ulcer can actually lose the whole foot if that ulcer is not properly managed. So why would people with diabetes develop foot ulcers? What happens? Well, usually when the blood sugar control is poor, or there is a poor blood supply to the foot, or the nerves are not functioning properly, that foot is prone to injury, and that could cause a foot ulcer. Also, people that have diabetes with some nerve imbalance or problems can have abnormal gait, and then they could also have foot abnormalities which predispose to ulcers. Also, people who wear wrong or fancy footwear are prone to foot ulcers. If you have diabetes and you're busy wearing stilettos or very, very funny shoes, you are putting your foot at risk for an ulcer. And then there are the traumas. A patient falls or hot water pours on him or something like that. Trauma can also cause a foot ulcer that fails to heal. And then sometimes infections in the foot can also lead to ulcers, which are either small or large. How do we grade foot ulcers? Because there has to be a way to know how to manage them. The ones that have a high grade, usually they require the person being hospitalized and several specialists being involved, while those that are of a lesser grade can be managed at the community level. So those that have no ulcer but a high risk foot, we say they have a grade 0 ulcer because they don't have an ulcer at that time, but they are likely to have one. If you just have a small abrasion or bruise on the surface of the skin, we call that a superficial ulcer, and that is grade 1. If you have a deeper ulcer, which appears to be penetrating and going a little bit beyond the surface of the skin, we say it's grade 2. But when it goes beyond the skin into the muscles, bones, and other areas, we say that is grade 3. And when a part of the foot dies, which is called gangrene, that is grade 4. If the whole foot becomes dead, looking either bluish or blackish, then we say the person has extensive gangrene. So grade 1 to 3 ulcers are termed non-gangrenous ulcers, and grade 4 and 5 are termed gangrenous ulcers. The reason why they are subclassified is because the grade 4 and grade 5 usually lead to either amputation of part or the whole foot. So the aim is not to get to grade 4 or 5. Again, looking at it pictorially, this is showing you the different grades which I just described earlier, ranging from grade 0 all the way to grade 5. And as you can see, the grade 5, usually the whole leg is blue or black and very often decaying or smelling. That is the worst of them, which is grade 5. What are the consequences of diabetes foot ulcers? Well, septicemia is a very worrisome consequence, in which means the leg that is infected, bacteria and other microbes migrate from the wound into the blood. And that's a blood infection that can overwhelm the patient and lead to loss of life within a few days. Also, if a foot ulcer is not well managed, it could move from the skin into the bone, and that will cause a bone infection called osteomyelitis, and it can lead to damage of the bone or breaking of the bone, and eventually that foot may need to have surgical intervention to take out the dead bone. Other consequences of foot ulcer that are not so common is tetanus, which is locally known as lockjaw, in which the person who has an ulcer sees that over time he can't really open his mouth, or is having twitching of the different muscle groups. That is tetanus. It's not so common in developed countries, but in developing countries, we see a few of them. Amputation is another consequence of diabetes foot ulcers. If the ulcer is not well managed or it is life-threatening, usually the surgeon has to make that unpleasant decision to take off that foot or part of the foot. And the last one is death. Quite a number of people who are very sick because of foot ulcers, some of them, even before they have the amputation, which is supposed to be life-saving, they could lose their lives to death. So these are the consequences of diabetes foot ulcers. So that's why we are taking it very, very seriously. Remember that the commonest cause of lower extremity amputation is diabetes. So if you see anyone who has lost a foot, you can guess that most likely he's lost that foot or leg to diabetes rather than accidents and other mishaps. How do we manage these foot ulcers? First of all, the person has to have a good nutrition because it is a wound and it requires protein to cover that wound. Then also you need good blood sugar levels, meaning that the person should have adequate control of his or her diabetes. Bed rest is very, very important so that you can take pressure off that foot. There's no point having a sore on your foot and you're using it to drive or using it to walk or jog. You have to be on bed rest so that that wound can heal. Other things that we do are to use appropriate wound dressing. There are different types of wound dressing for different types of wounds. And then antibiotics, especially where there is sepsis or there is a risk of septicemia, we put the patient on antibiotics. Debridement just refers to you excising dead tissue. If any part of the foot has tissue that is dead or decaying, you have to remove it so that it doesn't infect other parts. Other things that can be done for some patients include skin grafts, where you have a large surface of the wound that is exposed and you take skin from other areas to cover that part. Other management of foot ulcers includes limited or major amputation or trying to divert blood from one part of the foot to another part of the foot to revascularize or to improve blood supply to the foot. I mentioned the term earlier, which I said is offloading. If you want a wound to heal, then you must take the pressure off it. If you have a sore under your foot and you are walking on it, it will never heal. So you need offloading measures, and it could be as simple as taking crutches, using crutches, because if you're using crutches, at least that foot doesn't touch the ground. And then there are other offloading devices and shoes. As you can see in this diagram, these are offloading methods using different types of shoes to take off pressure of that wound and allow it to heal. To prevent foot ulcers, it's more important than actually treating foot ulcers because one is cheaper. Prevention is always cheaper than cure. So we tell people that have diabetes that please do not walk barefooted. We also tell them that you should have comfortable shoes. Don't wear exactly your size of shoe and don't force your foot into an undersized shoe because that could be the beginning of a bruise or an ulcer. People that have diabetes also need to regularly inspect their feet. If their vision is poor, then members of the family can inspect them. And each time, if you have diabetes and you get to a hospital, even before the doctor starts asking, start taking off your shoes so that you could show the doctor your feet. Early reporting of changes is very, very necessary. If you see your toe changing color, or any part of your foot changing color, you must report as soon as possible. And again, we can't overemphasize good glycemic control, meaning that good control of your blood sugar, your cholesterol, keeps ulcers away or helps to heal ulcers that have already occurred. Exercise is very, very important because with exercise, you can improve the circulation to your legs and thereby prevent ulcers. But when you're exercising, make sure you wear comfortable training shoes or sports shoes, and then have a good posture. So this is an example of proper footwear where you have a wide toe box, meaning that the front of the shoe is not cramped. You have thick soles so that even if you step on nails, they don't go through to your foot. The shoe must have flat heels so that you don't fall or trip. And then that piece of cotton wool-like stuff that you put inside is called an insole. A proper footwear should have insoles. Ideally, you shouldn't have straps or tongs. If you look at Roman centurions and Roman soldiers in the olden days, they tie some straps around the leg from the foot all the way up to the knee. But if you tie such, they might impede blood supply, or the pressure from those straps or tongs can actually cause an ulcer. Please, if your shoes are old, do not patch them. Do not start putting nails and clips inside your shoes because those things that are used to fix the shoe can actually injure the person wearing them. These are fanciful shoes, but they are bad medically because they put undue pressure on different parts of the foot. And because the front is so cramped and tight, you could have ulcers or corns, which lead to ulcers. So you must avoid bad shoes, no matter how fanciful they look, and go for functional shoes that can help you to prevent diabetes. For those who already have a wound, you must go for appropriate and regular wound dressing, and this is determined by the surgeon or the nurse or the podiatrist, the type of dressing that the wound should have. And it should be regular enough. There's no point dressing a wound once a week. Wounds must be dressed carefully, regularly, to control odor, to protect the wound, and to make sure that the wound doesn't get too dry or too wet. There are several other things that people do when they have wounds, and these include using wound healing factors. Usually they come as creams or sprays. And then in some wounds that are very, very dirty, meaning that there's a lot of dead tissue, in some countries, they actually have formulations where you can use maggots for therapy. Other things that can be done is revascularization. And by revascularization, which I mentioned earlier, I mean bypassing blocked arteries and then making sure that blood flow to the leg is good. Skin grafts, composite grafts, these are used to cover big areas of loss of skin. If there are problems with the bony alignment or with the ligaments causing the ulcers or the wounds, you could also invite a podiatric surgeon or an orthopedic surgeon to make corrections of these abnormalities. So in conclusion, there are many causes of poorly healing wounds, but diabetes mellitus is a major one. The best way to manage wounds and ulcers is to prevent them. And if you can't prevent them, detect them very early. Don't wait till the leg is very, very painful, very swollen, or wait until there are maggots coming out of the wound, or until a lot of bad odors are coming. At that stage, very often it's too late to save that foot. Management of foot ulcers involves assessing the severity and choosing an appropriate medical or surgical intervention. Thank you very much for your attention. I will take the questions at the end of all the other presentations, like with the others. Thank you.
Thank you very much, Prof. Yes, if you have any questions, just pop them in the chat so that when we come to the Q&A, you won't forget, and it will already be in the chat. So if you have any questions right now, just pop them in the chat and then we can attend to them once we go to the other speakers. Okay, let's go straight to the next speaker, which is Abiola Ogunlewe. She's a matron and a nurse at the Dermatology Rheumatology Outpatient Clinic at Lagos University Teaching Hospital, and has extensive experience with wound management. Abiola, over to you. We can't see you yet. There we are. Right, it's all yours.
Hey, thank you for having me. Thank you, Prof, for a very insightful lecture. The topic of today is the psychological and psychosocial effects of wounds. So I won't go in too much. Prof has done justice to all the other things I want to talk about. So I'll move right on to the case presentations that I've encountered in my course of work in the dermatology and rheumatology clinic. So the first case presentation is of a Charcot foot in a diabetic patient. Charcot foot is a rare but serious complication that can affect persons with peripheral neuropathy in diabetes mellitus. Prof has told us diabetes mellitus can cause a whole range of problems, and Charcot foot is one of them. And then this patient has been with us for like 4 months. He presented to the dermatology clinic for continuous wound dressing. Mr. O is a 59-year-old man from the eastern part of the country, married with 4 children, with a 10 years history of diabetes. And the Charcot foot started 5 years back. He has undergone 3 surgeries to correct the defects, which were not successful. This is a typical picture of the patient, Mr. O, that came in for the continuous wound dressing at the dermatology outpatient. During the course of, we've done the wound dressing, we've used several lotions, several treatment approaches without any success. But since the onset of the problem, the roles have been shifted from being a breadwinner to a dependent on his wife. He has had to depend largely on the income that comes in from the wife's petty trading. He seeks for help from family members because the way he is, he cannot work anymore to provide for the family. So it depends largely on the income that the wife generates to be able to fend for himself and to be able to afford the treatments that he has to undergo. And there have been occasions where he has requested for amputation of the limb so that he can relieve the wife and himself of the burden. Then when we talk about psychological effects of wounds, largely the caregivers too have a lot to share in the psychological and psychosocial effects. You see some of them complaining that is bringing them to the clinic is stressful. They can't come every day for wound dressings. Sometimes they miss the time they are supposed to come for their wound dressings. And when you ask them, some of them say they are tired of doing the wound dressing every time and there's no change. But we keep encouraging them. We've seen cases of where we have good success with wounds that have stayed for long in patients. And then Mr. O-Social's life has been non-existent since he can't attend social gatherings with his condition. He said he can't even recall the last time he attended a social gathering. Even his sex life has been greatly affected. And then he takes solace from reading his Bible and keeping indoors, watching television and reading and chatting with his children. A verbal consent was obtained for him from the use of this public image that will attach to his presentation. The next case is a leg ulcer in a sickle cell patient of 7 years duration. A 27-year-old female living with sickle cell and a non-healing ulcer on the right lower limb. Then sickle cell leg ulcer, a frequent complication of sickle cell disease. While the genesis of this ulcer is not completely understood, several factors are believed to contribute to the onset, which includes mechanical obstruction, venous incompetence, and trauma. Then the case presentation, she presented to the dermatological outpatient clinic with a referral from the surgical outpatient clinic for continuous wound care. She had had a skin graft done 3 years before, which was unsuccessful. And then during the course of the interview, she didn't consent for me to take her pictures, but she was willing to give other information. She has faced a lot of challenges with the wound, most times coming secondary among the myriad of issues she has to contend with. And for a sickle cell patients, sometimes what they have to contend with is much more than the wound. Sometimes the wound even comes second place. How to deal with not having crisis, doing our day-to-day activities without complications, how to survive the disease condition, financial challenges and activities of daily living, and coping with the care of the wound. She resorted to wearing a particular type of clothing to cover the wound. She has to be on her trousers every time. Sometimes she feels like she needs to wear a short skirt, but she cannot do that because of the wound on her lower limb. And then sometimes she blames her parents for putting her in this kind of condition, that if they were properly educated about the sickle cell factor, AS, not marrying AS, that she wouldn't be in this kind of situation. Then on her suitors, I mean, as a woman, she will want to have emotional circle once in a while from the opposite sex. But she told me that she hardly has any since the leg also started. And once the suitors discover that there's a wound, they call off the relationship. And then the only one that showed interest left her about a year when the wound wasn't healing, and the guy called it a spiritual attack. So she said life has been hard, but she's hopeful that all will be well. Then moving on to the third case presentation is a case of venous insufficiency and stasis resulting from a leg ulcer of over 10 years. Venous insufficiency is the improper functioning of the vein valves of the legs, causing swelling and skin changes. Normally, the vein valves bring blood back from moving towards the heart. Symptoms include extended veins, swelling or skin color changes of the affected leg. Then treatment can help, but this condition can be cured. This is a wound of the third case presentation. This wound we have been taking care of this one for the past 10, 12 years, if I'm not mistaken. It has been with us in the dermatology outpatient for a very long time. Sometimes the wound changes and it looks like it's healing up, but then it comes back to how it was before. But then in sharp contrast to all the other cases I've discussed, this particular case is of a 92-year-old man, and it gives us an appearance of joy and happiness without a care in the world. He walks with a noticeable swagger and a cap on his head that is sky high. You cannot help but notice him. We call him Baba, and he knows almost all that goes on in the unit. Whoever feeds him with information is still a mystery. There is nothing going on in the unit that he doesn't know about. There is not information that Baba doesn't know about. He knows our cadres. He knows last time we were promoted. He knows how many children we have. Everything on the units, he knows about it. Then he comes for his wound care whenever he pleases and anytime he wishes. When you try to educate him, he flares up and gets really aggressive. I think Baba has come to accept the wound as a part of what he has to live with and doesn't see it as a challenge. There was a time his children even got him a nurse to come to the house to come and do his wound dressing. Baba told me that he chased the nurse away because if he finds succor from coming from his house all the way at Ojolegba to Yaba to chat, to talk, to gossip. That's what he said, so that he doesn't feel abandoned in his house because he stays alone. He doesn't want anyone to live with him. And Baba has his bad days where he gets really quiet and depressed. And when you talk to him, he will say that he's 92, that why can't God just take him away? Baba still attends parties and mosques and goes anywhere he wishes to go. He hardly has a care in the world. Then I'll just touch briefly on psychological effects of wound. There's no wound that doesn't have pain. And there's anxiety and fear. Anxiety, when will this wound heal? Will this wound ever heal? And there's an alteration in body image. You have to address a certain type of way. Your lifestyle has to change and all the other things that comes with having a chronic and long-standing wound. Thank you for listening. I hope I've been able to do justice with the short time we have.
Thank you so much, Matron. I'm going to ask you a question. Just go back to your last slide, the last slide you had.
Last slide, okay.
Yes, if you could elaborate more on those last 3 points. You still have time.
Okay.
Thank you. Not this one.
Yeah. On the fear and anxiety?
Yes, please.
Okay.
Yeah, that one. Yeah, so you can expand a bit more, especially with all the case presentations that you've just discussed with us, which were fabulous. And for each one, just talk more about, those psychological effects and psychosocial effects that they had to deal with or are dealing with, and how it. I know you may touch them briefly, but you still have time, so you can go into more detail about these effects. Thank you.
So the psychological effects of wound, we have pain, like I said. Most times, for a wound that is long-standing, it doesn't absolve them of having pain, because whenever you do the wound dressing, they tell you that it's painful, that they can't cope with the pain, and that's why some of them come to the clinic whenever they miss days of coming to the clinic. And then you have to put them on medication for a while, for pain medication, before you can continue with the wound dressing sometimes, especially the lady with the sickle cell leg ulcer. There's no time you want to do a wound dressing that she doesn't complain about pain. And then because the nerves are exposed, and of course there will be pain. And then on anxiety and fear, this is a major one. Most times they tell you that, matron, is this wound healing? Is there any change in the wound? Sometimes they even ask us, are you not tired of doing this wound dressing? You keep doing it every day and there's no change. But we keep encouraging them that there's hope. There's hope. We'll keep encouraging them. We don't give them a gloomy feeling that this wound will not heal. Of course, we are helpful too. And for caregivers too, sometimes we get tired too of cleaning these wounds and we see that there's no change. But of course, we don't show it to the patients. Just have to encourage them. Then the alteration in the body image. For all the case presentation I've said, the Charcot foot has to use crutches. He doesn't have to, he can't go to any social gathering. He has to wear a certain type of shoe for him to be able to cope with the wound on his leg. The lady with the leg ulcer has to wear trousers or a long skirt every time. And their body image, why can't I wear whatever I like? Why should I wear trousers or long skirts every time? Why is this happening to me? So there are lots of questions that they ask you, and they show worries over. And then for Baba, like I said, Baba, I think he has come to accept the wound as part of his being. But notwithstanding, if you check, with the way he dresses, his trouser, he mostly wears Ankara trousers. He has to sew the one leg of the trouser a bit bigger than the other leg, because to accommodate the size of the limb. So there's a whole lot of things that occurs when a patient presents with long-standing wounds.
Okay, so there was one interesting one you were talking to me about the mama lady.
Baba.
You want to briefly talk about that? You have time, so you can elaborate. Baba? No, not Baba. The other mama lady that you said was on her own. Okay, how she was trying to cope, the psychosocial effects on her.
Okay, there was one other that she's not part of the case presentation. Can I talk about? Yeah, that's
fine. Yeah.
Okay, so we have another elderly woman. I think she's in late 80s with venous insufficiency also, and then because she's a retired nurse, she has stayed in the UK for a while, but she had to come back to Nigeria because she couldn't see any help over there. I think when we started our wound dressing, she hardly complies with whatever you tell her to do. She has a hearing aid. I think Mama, whenever she comes for the wound dressing, she will tell you that please don't clean it too much. It's painful. It's this, is that. I think for a while now, I've not seen Mama in the unit. I think she got tired of coming for her wound dressing. And then our children too were a bit worried about her care. I think she only comes to the clinic with her driver once in a while. The driver will bring her for the wound dressing. She's supposed to come to the unit for the daily wound dressing, but she comes, I think, intermittent days. And when you ask Mama why has she not been coming, she says she's tired of coming for the wound dressing. When you try to tell her that there are some things you need to do for her to make the wound heal up, Mama says she's tired of coming for the wound dressing. She does it. She's old. That whatever the wound likes, let the wound do to her. I think I didn't have really much to say about Mama.
Okay, so with all these patients now, with all these presentations, how have you supported them with the psychological effects and the psychosocial effects from the wounds that they have? How have you supported them, one? And if they have any family or carers, I know, the psychologist might talk about it later, but, what have you done practically to support them and things like that?
Okay,
Philomena, I see your hand. We'll come to you in a minute.
like for the lady, whenever she comes to the clinic, we try and ask her how she's feeling today. Did she go for a follow-up clinic? Is there any change in the wound dressing regimen? We try and talk to them, we try and encourage them. And then sometimes we tell her to take pictures of the wound so that she will check the progress. And sometimes she has bad days and good days. On the good days, we all rejoice and we encourage her that the wound is healing. And on the bad days too, we try and encourage so that, okay, let's try something else. Okay, we've been using this solution. Let's try another solution. Let's see if it works. If it doesn't work, we try other things that could work. So we try and whenever we see them, but for days we don't see them, we try to call them. Miss, so why are you not in the clinic today? We've not seen you for a while. Sometimes they tell them that, yeah, I'm sick, I can't come to the clinic. Okay, I don't have money for transportation. Okay, come to the clinic, we'll see what we can do. Sometimes we have had to give some of them, like the lady, money for transportation to come to the clinic for her wound dressing. And sometimes we've had one of my colleagues that stays near her go to her house to do her wound dressing if she cannot come to the unit. Then for Baba, Baba is one you cannot talk to. I think when you correct Baba, he doesn't listen. Baba doesn't listen to anything. When you try to encourage him, he said, Baba will tell you that I'm old, let death come. So Baba is one special patient. Then for Mr. O, the one with the charcot foot. The last, I saw him 3 days ago, and I asked that, Baba, do you think this wound is healing? He said he doesn't know, that he doesn't think the wound is healing. The wife usually comes with him to the unit. When we asked her that, because the last time she came, she was in quite a bit of a hurry. We now asked her, why are you in a hurry? She said she has customers waiting for her at the shop. She has to hurry. I said, okay, hold on, let's talk to Baba. Baba will say, no, he's in a hurry, let's go. But we try our best to encourage them and to give them a ray of hope that the wound will heal sometime.
Thank you, Matron. Just stop sharing for me 1 minute. I just want to welcome everyone who's just joining us. This is a learning environment. We're here to support each other. We're talking about the psychological and psychosocial effects of wounds. If you have any comments or questions for the current speaker, because we'll still do a Q&A at the end, just raise your hand and let's make it interactive. We're all here to learn and share and develop so that we can all improve our skills and provide better care for our patients. Okay, Bumi, where are you? Go for it.
I am here. Good afternoon, everyone. And yes, welcome to Encapsulate Solutions. I love being here. I'm not a professional, but every time I come, I always learn something, and I've learned a lot today. So welcome. Thank you all for joining. I'm going to take the first question. I think Philomena Okonye, if you just can unmute yourself. I've asked you to unmute. Thank you.
Yes, can you hear me now?
Yes, we can.
Hello?
Yes,
okay,
we can.
My name is Philomena Okonye. I'm calling from Texas. I was very interested in what she said. I understand she was talking about, you were talking about venous insufficiency with wound. What advice would you have for somebody who has venous insufficiency that doesn't have wound yet, so that they can prevent the wound?
Nature, do you want to take that?
For venous insufficiency, we usually tell them to elevate the limb. And then there's a pressure socks that we usually advise for them to wear. It acts like a compression on the limb, on the affected limb. So the compression socks helps a lot, and then you elevate the limb that is affected. Whenever you're seated on a chair, you try and elevate the limb on a chair or a stool for venous return, and then you wear your compression socks whenever you're not seated.
Okay, thank you so much. I appreciate it.
Thank you.
I don't know if Prof wants
question.
to. Sorry, I don't know if Prof wants to add to that question.
Yes, well, she has answered very, very correctly. Usually when you do have venous ulcers, depending on how severe they are, most of them you manage them conservatively, which means when the person is lying down, you elevate the leg, person use a compression or TED stocking to compress the veins. And then for those who are overweight or obese, we advise them to lose some weight. And if it is quite bad, sometimes the patient may actually need to see the plastic surgeon so that the underlying cause can be corrected, meaning that some of those veins can either be stripped, and then if necessary, the person can have a skin graft. But usually most of them are managed conservatively, just as Matron has mentioned, elevation of the foot, compression stockings, and that will prevent ulcers from occurring.
Thank you very much.
Thank you so much for answering that. The next person is Essay. Essay, if you can just unmute yourself and ask your question. Thank you.
Okay, good afternoon. My name is Essay from the News Agency of Nigeria. Yes, I want to ask, when managing these patients, do you work hand in hand with psychiatrists, psychologists who can help to manage their psychological problems? Thank you.
Matron, that's for you.
We haven't really seen one that we refer to a psychologist or a psychiatrist. I think now that you said it, I think is an essential thing that we have to do for some of them that are willing to do that. I mean, I know that in our culture, there's a stigmatization attached to you suggesting to a patient to see a psychiatrist or a psychologist. They may tell you that, do you think I'm exhibiting symptoms of mental illness? So I think we haven't really done that in our units. So I wouldn't say, but I think it's an essential thing to do going forward for some of these patients.
Does that answer your question, Essay? I think you muted yourself. All right, okay. Baku Ali, I saw you raise your hand. If you want to raise your hand again so we can tell you to unmute. Baku Ali, you had your hand raised.
Hello.
Okay, go for it.
Yes. Thanks for the thought-provoking lecture. We see some of these things once in a while. Can you enlighten us more about the symptoms, early symptoms? Is it treatable at the early stage of manifestation? So if there are solutions, please, can you give us more on that?
In relation to what? What type of wound? Which specific condition are you talking about?
The last lecture.
So are you talking about venous ulcers, or what specific condition are you talking about? So that she can.
Venous ulcer. I know that there was an advice that maybe there is a special socks for such a condition. So please, I don't get that area very well.
Okay, Matron. Is this talking about venous insufficiency? If I'm not wrong.
Yes, please.
Like Prof said, we usually tell them to wear compression socks. You elevate the limb, and he also said that if you're overweight, you try and shed off some of the weight. But that if it gets complicated, you see a wound surgeon for that. I don't know what else you were asking about.
Bakwali, do you want to elaborate? Or you can type it in the chat.
Okay, I will check. I will type it in the chat.
All right, thank you.
Thank you.
Thank you so much for that. And the next person we've got is Darren Moore. I've asked you to unmute yourself, Darren, if you can ask the question.
Yeah, good morning, everyone. I just wanted to add to what the matron was saying. I think I'm usually based in the UK, and when you're treating clients like that, I think the first thing to do is to actually speak to them about what is going on. And I know that they will have hesitation and all sorts of things. So I think it's really a change of mindset to encourage them to speak to somebody else in the form of a psychologist or psychiatrist. So that person will be able to manage their mental health, because everybody has some form of trepidation when it comes to seeing a doctor or a nurse or whatever. But if they work hand in hand with a psychologist or a psychiatrist, I know that back home is stigma, but these days people are moving forward and changing their mindset, and it is us healthcare professionals that need to do that with them and empathize with them, because I know it's very easy to move back and just treat them like patients. So my take on it is to treat them like, to empathize with them and bring them along. Especially I heard you talk about the man and the wife who would rush out and everything. It's because maybe they feel as if their statistics, their numbers, and nobody is actually empathetic towards them. I know it's not easy, but that's the way we should be going forward from now, to empathize with those people who come in and, care about their aftercare, so that they'll be encouraged to come back and open up to some other healthcare professional, even if it's not people who are there. So it's just my toppings. Thank you.
Yes, I agree very well that one has to broach the topic and introduce them to the mental health workers, even though in Nigeria, it's a big stigma when you do refer such patients, but one just has to find a way to let them realize that a problem shared with a specialist in that field is a problem half solved.
Thank you, Prof. Thank you, Prof.
We've got one more hand up. Mojokwe Oyawole.
Hello. Yeah, good evening, everyone. Good day.
Good evening.
Because I know there are other people from other places. Okay, so I want to say it's a beautiful presentation, to agree with what most people talked about. I'm a clinical pharmacist with bias in diabetics. But my own take is, how do we do more of prevention than even allowing it to come down? Because you find a situation where your patients early enough, you started seeing signs or they are already complaining to you about some top 2 signs of neuropathy, and then the ones that have venous insufficiency, it really cannot, they can't differentiate, So it's our part as healthcare providers to see how do we come in to even get them early enough before they get to a stage where it becomes so bad, and then they now have a wound that is not healing. So what do we do? How do you really suggest that we do more of aggressive catching up with them early enough before they get to that stage where it's almost like irreversible, whether for diabetic nephropathy or venous insufficiency or any other thing that can make them to come to a stage where the wound is not really in fast, apart from the psychological part of it that it seems to be dealing with. Thank you very much.
Who wants to take that?
It was a long question, so
It was. You're digesting it.
But actually, the management of wounds is quite complex, and it is a multidisciplinary affair. Matron is doing a wonderful work. The plastic surgeon sometimes weigh in. We might sometimes need the input of microbiologists sometimes the input of cosmetics people, sometimes the input of those in prosthesis. Sometimes you need to actually culture the wound or parts of the wound or take a biopsy, so pathologists too can be involved. There are so many people that are involved in the management of leg ulcers. The psychologist is there, the psychiatrist is there, those who dress the wound, sometimes even community health workers, because some of the patients can't even afford to come to hospital every day for regular wound dressing. So in some that are not complicated, you even have community health workers or community extension workers also helping to manage these patients. And the burden on the patient is so much that quite a number of times they can even go into financial distress, because you can imagine having to go to a clinic where you are charged about 2,000 naira for dressing, and the doctor says it's daily dressing, and he has to take transportation to get there. Sometimes he needs antibiotics, he needs to buy all the different things. So it is quite challenging, and there are so many people that are involved. There's one question in the chat box that says, what are the modern methods of dressing wounds? There are so many types of wound dressing. If you allow Matron to go to town on that, we'll be here for the next 1 hour. There are some dressings in which there are pressure. There are some dressings in which you use vacuum. There are some dressings in which you use alginates, some dressings in which you use potassium permanganate, some in which you use USO. There are different dressing agents. There are different dressing materials. There are different dressing types. So that on its own is a very, very, very big area. So we have tried as much as possible not to go too much into clinical detail, because we know that not everybody on the call is a healthcare professional. That is why we have taken everything very, very simply. We've not gone deep into the different aspects of wound care.
Thank you very much, Prof. Okay. We have lots of questions, which we will get to towards the end, but I want to bring on our last speaker. But before I do that, I just want to say again, welcome to everyone. If you're new here, my name is Flora Coker, and I'm the founder of Encapsulate Healthcare Solutions. And the vision of the organization is to equip healthcare professionals in Africa to be able to, continuously improve their skills and provide better patient care. It's all about the patient. And we also, want to encourage multidisciplinary team working. So that's one of the visions of the organization. I will now introduce our third speaker, Olabode Daramola. Let me just get his bio. All right. So Olabode Daramola is a clergyman, a licensed clinical psychologist, and is the managing partner at Hemisphere Consult. He has over 18 years experience in client management, quality assurance, training, and administration. His current scope of work includes psychodiagnosis and therapy. He manages clients with anxiety, depression, grief, trauma, substance abuse, and maladaptive behaviors. He holds an MSc in clinical psychology and also a Master of Managerial Psychology from the University of Lagos, where he's currently a PhD researcher. He's also a member of the Nigerian Association of Clinical Psychologists, the Learning and Development Network International, and the National Association of Cognitive Behavioral Therapists in the USA. Bode, over to you.
Good
there you are. I was looking for you.
Okay, yes, I'm here. Good evening, good afternoon, good morning. Good day, wherever you are listening from. I appreciate you, Flora, for the opportunity to be able to come up here again this evening. And I also want to appreciate the other speakers, particularly Prof, who has laid a very good foundation for this topic, and to our nurse as well. Sabiola, thank you so very much for what you've done. You have made it a lot easier for me. I appreciate everyone for joining. And I hope we're sure having a good time in here. So let me try and share my slides. I hope you can see what I have. Okay, psychological effect of wounds. Learning points for today, hopefully from the introduction, we'll be able to understand what psychological health is. Prof has spoken about wounds. I'm just going to make one or two comments about that. And wound-related factors affecting our daily lives, or that could affect the daily lives of patients. I'll speak about that. And the psychological effect of wounds, then the wound healing. What can we do from a psychological point of view to help patients? And then how can we maintain psychological health? And then we'll conclude. So based on our discussion, one thing we have been able to realize is that wounds and healing is no longer a purely medical phenomenon. And with everyone that I've spoken, people have agreed that there should be a multidisciplinary approach to healing, as it were. And there are growing evidence that actually confirm the psychological impact of wounds. And I'm going to share some of that with us as we go on. And in fact, I would like to tell you that the psychological effect of wound is actually a vicious circle that we cannot overlook. And this effect can actually take two forms. The psychological effect of wounds in itself and the impact that this effect can have on wound healing. And so whether we like it or not, wound will definitely affect our psychological health. So what is psychological health? I want us to have some understanding of that before we move on. So psychological health, as defined by the American Psychological Association, is simply optimal living. Optimal living. Now, what does it mean to live optimally? You agree with me that if someone is wounded, there's a part of your body that is taking off, and you have to depend on people to take care of you. Would such a person live optimally? So psychological health or optimal living, as it were, is a reasonable and continuous finding of satisfaction in one's living. So the question is, as a medical professional, for that patient you're attending to who has a wound, are they living the optimal life? The second criteria is the utilization of a problem-solving mode of behavior, even while the treatment is going on. There are some patients who want to even reject, just like the nurse mentioned, there are some patients who want to reject treatment, who will say, oh, I just don't want to continue, I do not see this working. Rather than focus on the problem-solving mode of behavior, some of them will want to use the escapist mode. Oh, can we just stop this thing? Let me go ahead and just pass on. I don't think there's any reason to leave. While the nurse was talking, something just came back to my mind during COVID-19. I had the opportunity to be able to manage some COVID patients, psychosocial support. There's a particular woman, 70-year-old, I'll never forget that incident. She told me that she has no reason to leave and that she wants to go. I had to remind her. I asked her a question, ma'am, when last did you see your grandchildren? It's been a long time, because some of them are not even in the country. I said, would you love to see them again? She said, if God wills. I said, but do you know that if you stay alive, if you take your medication, if you do what the doctors and the nurses have asked you to do, you may get another chance, another opportunity to see your grandchildren again. He said, are you really serious? Do you think if I take these things, I'll be well? I said, Mama, please try. Go ahead, take your medication, do what the doctors and the nurses have asked you to do. Then she continued and she survived. After COVID, I was able to see her. And there were a lot of people who gave up during that period because they had no support. And another thing, ability to perceive one's environment with relative freedom. Somebody has a wound, the who's, the malholder. They usually want to stay away from where people are. So they don't perceive the environment as being supportive. There's some kind of distortion. They can't go out, they can't attend parties. These are some of the things that will not even help them to be able to live optimally as a result of the wound. Then optimal living, is a personal well-being and happiness without reference to the views of other people. I can tell you as a health professional, for every patient you attend to, while you talk, while you are not talking, they listen to your body language. They are looking for validation. In fact, without you speaking, for example, when I walk in to see a doctor, after all the tests, without speaking, I look at their body language and you're wondering, what is the prognosis? What is going to happen to me? Is there a surgery? So we're looking out for information. And so the moment you come and you look all gloomy, we already know what's going to happen. But even in the midst of all the bad news and all of that, when you come in looking all positive, it will encourage a patient to stay alive. So let me just move on. I know Prof has spoken about what a wound is, but I would just like to stress something here, because when somebody saw this topic, he was asking me, oh, I mean, what are you going to be talking about? Are you going to be talking about emotional wounds or trauma? I said, this one it has to do with physical wound. So wounds can either be physical or emotional. So for a wound that is physical, like we are talking about, there are emotional pains that are also associated with it. And those emotional pains are what the psychologist should be able to take care of. You have an important event you are not able to attend because of your wound. There are certain important things going on. You just cannot, you're someone who is bedridden. They want to get out and live their normal life, but it's impossible. And do you know that your mind cannot differentiate between the two? Either the pain is physical or the pain is emotional. The brain understands it same way. Let me just give you, if you are there with me now, can you for a moment, just listen to me for a moment, can you for a moment not think, please do not think about wound. All of us that we are here, there are 85 of us here now, can we please don't think about wounds? Is it possible for you to do? You may want to put it in the chat box, because we've been talking about wounds. Now, if I say do not think about wounds, are you able to do that? It's very difficult because our brains don't think in negative. It thinks in positive. And that's why when something is happening, we must be able to give people another option. And that's what we do when we say we're doing CBT. If I have this option, is there a replacement? So whether we like it or not, either the wound is physical or emotional, the brain understands it the same way. So the same flooding of neurotransmitters, the pain relievers occurs in both wounds. For example, somebody may be asking, what's an emotional wound? Temper tantrums. Very early this morning, I was woken up by a couple. The wife left the house. The husband was angry, and usually in his anger, he uses words, temper tantrums. Those words actually caused the wife some pains. That's emotional, and she left the house. It has its own effects. As much as the physical wound can keep you on the bed, an emotional trauma or wound can keep you out of your husband's house. So how about that? So the two complementary nervous system, you have your sympathetic, the arousing, or the parasympathetic, that calming effect, they are essential for psychological balance in both physical and emotional wound. But back to what we're discussing. There are certain wound-related factors that could affect our daily lives. From a patient's point of view, let's just look at this diagram. Somebody is on the bed, they can't do what they would usually do. There's loss of control. The feeling that their life is dominated by wounds and the need for care. Then being dependent, it's not everybody that loves being dependent on people. We should know that. Then some often feel like a burden. Why do people need to take care of me? Why can't I take care of myself? How long would this go on? When would this all end? And there's something very important here before I forget. For everyone who is into wound care, it is important that we let our patients know that this thing is just one step at a time. And we must tell them that you don't have to heal 100% to improve on your quality of life. It takes a gradual step. Some people are waiting until they leave the bed to start their life all over again. Some people are waiting until they don't even see any traces again to start their life all over again. To always remind your patient that you don't have to heal 100% to improve on your life. But most importantly, take baby steps. Some of them may just not happen pretty much on time. I'm sorry I had to sound like that. This the psychology in me wouldn't. I mean, let me just wait on that. So low mood and depression, feeling of isolation, loss of pleasure, which I'll still talk about. They are disinterested. No joy in daily activities. Some don't want to wake up. They don't want to have their bath. They are even used to smelling the ooze. Have you ever stayed with a patient that has a wound in the hospital? I once heard of a close family member who had an orchidectomy. And unfortunately, while the wound was healing, the doctors and nurses went on strike. And so for about 3 or 4 days, he wasn't attended to. And for me as an individual, everywhere I go, I perceive something that smells, that oozes as that same wound. And it was difficult for me to even get over it. Thank God he's still alive, he didn't die. I wish he was here with us on this call. So loss of pleasure, joy in daily activities. What about the detrimental impact on relationship with your partner, children, and others? Loss of independence, reduced mobility. People want to move in life, whatever it is, no matter how hard people want to work and move. But sometimes these things can actually confine people to their bed. Changes in lifestyle. And many times when we preach changes in lifestyle, it is good, but sometimes these things are backed up with finances. If you don't have the right finances, it just may be well difficult to actually make some of these changes. The financial worries is there. And then, of course, unemployment. For somebody who is still taking care of themselves, they consider how useful they can be to the environment or useful to themselves and the people around them. So let's move on. What are the psychological effects of wounds? I actually had to do some search. A lot of work has actually been done in this area, as in the field of psychology. So psychological consequences of wound may result from the wound itself, the pain that is associated with the wound, and the social or physical consequences of the wound, such like malodor and the high level of exudate. I'm sure when some of the pictures were coming, I had to actually do some form of deep breathing, like, oh, everybody just needs to take a deep breath. Maybe everybody on this call, there are 82 of us right now. Can we just, if you are sitting and your leg is not touching the ground, try and put your legs on the ground. If you haven't changed your position since we started, try and change your position. I'm going to ask you to do that breathing. Can you just take a deep breath in and then take it out? Can we go in and then take it out? Can we take it in and then let's take it out? In again and out. And for the last time, take it in and out. Yeah. Sometimes you need to even calm your patients down before you do that dressing. Before you remove the dressing, these are some of the things you can actually use to calm your patient. But as we go on, from Arden and Eva, they said the effects of wounds can increase anxiety and depression. It can also increase embarrassment, negative body image, which the nurse has talked about, and of course, social isolation. Then patients often feel embarrassed about exudate leakage and malodor and have difficulty maintaining their dignity and their outward appearance. There's a case of a very young boy who, in Nigeria, who was affected by an inferno. And so the wound healed, surgery and all that was done. By the time he went back to school, people started calling him masquerade. He couldn't remain in the same school. He was emotionally down. He was a high flyer. Before this fire incident happened, first day in school, people were calling him Ojuju Calabar. Let me just use the word. In Yoruba, it means masquerade. I mean, you can imagine that effect. The change in the body, the change in appearance. He wasn't able to maintain his dignity. People were body shaming. I mean, people were talking about it because it was never himself. He had to get back home to look at himself over and over again because before he could eventually. And do you know that some parents even withdrew their children from that school because of what was going on. At the end of the day, he found another place where he found hope. So as we move on, a negative spiral could occur in which the wound causes a negative emotional state, and that has an impact on the wound healing, which in turn leads to further negative emotions. So some patients feel unable to go out, adding to the level of anxiety and feeling of helplessness that is experienced, according to Wu and the others, 2009. Then social isolation may be an everyday experience for patients with wounds, as they are forced to limit their activities to try to avoid pain. There's social isolation on one side, and there's also social suffocation. You keep such a person within the house, you don't want them to go out because of what they are going through. Social isolation can also affect social interaction, wanting to talk with people, which may lead to a tendency for patients to keep problems to themselves. They don't want to speak to anybody, they don't want to speak out. But the good thing is, the world of therapy, psychological first aid, and real aid is gaining more grounds in Nigeria. There's so many therapists who are doing well in their own way in Nigeria. We just have to find the right one. And for referrals, patient does not necessarily need to leave the confines of the hospital before they can speak to someone. Intervention can be given virtually. If you discover that this patient is being treated 1 month, 2 months, 3 months, there's no improvement, they might just need to start speaking to somebody and things may get better. And when you're a psychologist in Nigeria, people talk to you about almost about everything. Somebody woke me up this morning and it has to do with the heat. Like, oh, the weather is so hot. And you can imagine if you have patients with wounds, what would the weather be like for them now? And for a country like Nigeria, power supply is as good as zero. So how are they feeling at the moment? Is the room well refrigerated? What are the hospital condition? What is it like? Even some of these things may even impact on healing if we look at it. I have to encourage that person. I do not worry. All through the year, we've had rains falling. I mean, very soon Harmattan will come. We just have to be happy. A lot of people need encouragement if you ask. So these are some of the things we can do to make life easy for ourselves. So social isolation may occur if an individual lacks energy, and lacking of energy could also come because of sleep deprivation. People find it very difficult to sleep because of pain. And if people do not sleep, I don't know if it was Prof or the nurse that emphasized the importance of sleeping. I think it was Prof that mentioned it. People need to rest. They need to lay down for healing to take place. But when the pain is much, the weather is uncomfortable, they find it very difficult to sleep. So sleep plays an important role in healing process, and lack of sleep can interfere with our immune system. Like I tell people, no matter the amount of drugs and medication that you're given, if you don't get enough sleep, it will affect your immune system. And if the immune system is not all right, I don't know how healing is going to take place. So there are lots of other research that can go on to support the effect of sleep. I have this one. Price and Harding, 1993, they suggested that among 80 patients with chronic wounds, 25% reported that at least 3 nights sleep had been disturbed as a result of their wounds. They were finding it difficult to sleep. And moreover, out of these, 49% had experienced disturbed sleep on 6 or more nights as a result of their wounds. And so if somebody cannot sleep, how would that healing take place? So Ireland reported that sleep disturbances were a major source of fatigue and worry, as patients spent a great deal of time thinking about their wounds, overthinking, not being able to help themselves. Or maybe sometimes when they are not even getting support from carers, some people are abandoned by their carers, the negative things we say to people, it could impact on the psychological health. So this can therefore have serious effect on an individual's quality of life, as earlier mentioned. So many other researches that we can think of. Let me talk about, if I put anything here, it must be important. So similar results were found in research conducted by Harley et al. 2009, who suggested that patients with chronic wounds most frequently report.
Can everyone hear him?
No, we can't hear.
Okay.
No.
All right. Looks like NEPA or somebody wants to interrupt our flow this afternoon.
Can you hear me?
Okay, we can hear you now. So
Okay. It
yeah,
just
you froze for a
suddenly.
minute. So just reshare
Yeah.
again.
Okay.
Thank you.
Are you seeing the screen now?
Not yet.
Okay. Try and see.
Okay, while he's getting his slides back up, if you have any questions, like I said before, so that you don't forget, just write it in the chat. And then when we come to the question time, you'll be able to remember when we go through the questions. And I hope you're really getting some useful information today.
Trying to bring that up at the moment.
Okay.
Okay, it's coming right up.
All right, that's fab. Thank you. So just a shout out to everybody joining from Nigeria. If you've joined from a country that's not in Africa, please type it in the chat so I can say hi. Thank you for joining. I think someone said they were joining from Texas. Good to have you with us. But I still say hello to my peeps in Nigeria so they don't get upset with me. Thank you all for joining. All right, the slides are, yeah, I can see them now.
Okay,
Perfect.
they're back now.
Yes.
So still talking about the psychological effect of wounds. Found this again, Ellen et al. They suggested that patients with chronic wound most frequently reported trouble, sleeping, frustration, anxiety, and mobility problems. So there's increased level of anxiety and depression, which are shown to be more predominant in individuals with wounds. This can add to the effect of sleep deprivation. So what of pain? Pain is usually reported as one of the main reasons why individuals with chronic wounds have sleep disturbances. Wu et al. The citations that I have here, just to further substantiate the importance of the discussions that we are having today. So basically from all what we have said, the psychological effect of wounds, anxiety, and fear, the nurse has mentioned that, but we can, from the onset, every patient wants to know, am I going to die here? Are you going to cut my legs off? Would I be able to walk again? These are some of the anxieties that people have. From the point, will a doctor be available to the very end? Are they going to go on strike? Will there be power when the surgery is going on? Do I have the best hands in this place? These are some of the anxieties that patients go through. And I can tell you in Nigeria right now, we're in a very difficult times if you ask me. People will just tell you, you don't want to be sick. Because majority of the doctors who are to attend to us are not even available, brain drain. People are leaving, So the point is just remain healthy. And for most people, when things are not going on well, they just find other means till they pass on quietly. May God help us. So you must understand that the anxiety and the fear is there before they come to your clinic. And this we have to deal with before we start talking about healing. Most of the doctors that usually attend to me, majority of them have left the country. I could pretty much tell you that. The ones we have, they are overworked. So sometimes we don't blame doctors if they are not able to provide some of these other services that we mentioned. So many patients and other things. So alteration in the body, the nurses mentioned, the fact that there are changes. I tell people, okay, I'll still get to grief. Maybe I'll mention it when I get to that. Or since it even came to mind now. Alteration in the body, when there's a change in somebody's body, trust me, they are grieving. Somebody has breast cancer, a woman, and that part has to be cut off. That is some form of loss of identity. And so I tell people, when people are grieving, it is not only when people die that people are grieving. When a part of your body is severed, people need support. You could see the pain, you could see the anxiety, you could see, that moment of loss. So many things that they are not even able to share with people, but is going on in their minds. And this can impact the immune system as they go along. I wish I could even stop here. But hey, let me talk about body dysmorphic disorder. You realize that most of the patients you treat, for those who do plastic surgery, there are patients who will spend hours touching that area as if they could fix it. You know, body dysmorphic disorder is a mental illness that we need to pay attention to. It's an obsessive focus on that part of the body. They want to touch it even when they are not supposed to touch it because they want the skin to be flawless in appearance. And some of them, if you pay enough attention to them, if it's on the face, they will want to wear makeup and even overuse the makeup. These are some of the signs of this BDD. So you need to pay attention. It's as a result of your psychological impact of wound. Then, of course, depression, loss of interest, persistent sadness, and of course, anhedonia, the things that they are interested in doing before they are not willing to do. And even after the treatment, even after some have gone home, you realize that they gladly avoid that party, mingling with friends, because things are no longer the same. The emotional pain based on what they have gone through. I have also mentioned grief, loss of identity, and then you know that even loss of autonomy for most patients. The fact that they can't do things by themselves. The fact that they can't sign their checks by their hands, that be with a stroke patient. The fact that they cannot even do the daily things of life. It's part of, these are some of the things that impact them. When am I going to be able to use this hand again? When am I going to be able to use that leg? Will I be able to attend parties again? All these things, we need to pay attention to them. And then as we move on, because of our time, physical pain, then you reduced self-esteem, sleep disturbances, social isolation, social suffocation, and the stress that is involved in treatment. The hours of traffic on the road, and then, that people have to go through before they get to the hospital. And then when they get there with the pains on their leg, the hours they spend on the queue, waiting to get assistance, is a lot of stress on them, and then wound healing as well. So for wound to heal, I'm going to have to say that social support is very important. Support from family members, support from nurses, apart from the medication and the care of the wound, the things we say, our words, can be encouraging to patients. And then sometimes emotional disclosures give the patient the opportunity to express themselves. How are you feeling? And then whatever we want to do, we should take our time to explain it to the patient. Oh, good morning, Mr. So and so. This is the reason why I'm here. I'm not here to inflict another pain on you. I'm here to ensure that you get well. The things that I'm holding in my hand, this is what I'm going to be using it for. And you have to give me some minutes to be able to do this. It's not going to take long. You know, those words of encouragement. Then let the patients also speak about their healing processes, when you review them. Then multidisciplinary approach to management, we have mentioned it. The psychiatrist is needed, the psychologist is needed as much as we could do. I know in Nigeria there are lots of challenges, but let's move on from the challenge. That's why this program that we're having is equally important, that we get better in the things that we do. Then psychoeducation of caregivers. Sometimes when patients, they go from the hospital and then back home, are we educating the family members? Are we educating the carriers on the best way to do it? And do we ensure that they do it very well? And then for patients who you discover are no longer responding well, or you have an incline that these people may just need psychological assistance, they will need psychotherapy. Being able to talk and express their mind, they will need somebody to actually listen to them, and hear them out. Then for cases, that talk therapy cannot handle, some may need medication. That's where you need the input of a psychiatrist, which is very, very important that we do. And then for all of us health caregivers, I know that we are big on IQ. We are intelligent. Professors, medical doctors, pharmacists, trained nurses, they have high IQ to be able to deal with people. But we need to be big on emotional intelligence. And this is where empathy comes in. When we put ourselves in the patient's shoe, we probably want to do better. If that patient is your wife, your brother, your dad, or your mom, would you do differently? That's the question we need to ask ourselves. So we have to be emotionally intelligent, being able to manage our own feelings, and then understand the way the patients feel, and using that to manage their whatever challenge that they are going through. Our patients are looking for validation from us. You know, there are experiences, I just don't want to start sharing. You know, there are things, even when you think of certain things in your mind, you don't have to let the patient hear it. People say that even when a patient is dying, the last thing to go is actually the hair. So their sense of hearing, they could still hear. So when you are saying, oh, there's no water, light has gone off, the patients can hear. That one can discourage them. Or, oh, this patient is going to be here for a long time. They're actually discussing with a colleague, the patient will still be able to hear. So we have to be careful what we say as we take care of them. If we need to catechize, we can go out of the words. You know, we can talk to other people, because I know that for some of us too, they are stressed. May God help us. So how can we maintain psychological health? I hope I'm not speaking too much. We could have some patients who are listening, or those who are supporting people. How can we maintain our psychological health, either generally or in wound care? The patient must accept themselves. Once something has happened to you, you know, there are certain things that happen in life you don't expect them to happen. But if it has happened, you need to accept the situation. You're on that bed at that particular time. You need care, and you must accept that you really need it. And that's where you need to care for yourself. Love yourself. Care for yourself. Date yourself. Marry yourself. I tell people, if you are in the hospital and you're trying to get well, if you have never been selfish before, be selfish. Focus on your care. I told somebody recently, oh, your wife has done you this, your husband has done you that. I said, why don't you for once practice sologamy? Marry yourself and get healing and get help. Because when you get well, that's when you can get so many husbands or so many wives all over the place. So you were created, yes, God created you for himself. And then at the end of the day, people will ask you, how have you been able to manage your health? There are 3 stakeholders who are important in our health. Number 1, I believe, is God Almighty. Number 2, yourself. And number 3, others. So the others are the doctors, the nurses, the therapists, you know. But God, you yourself. So take your medications, eat healthy as you're supposed to do it, to accept yourself. Then self-determination, you must determine to get well. Then nurture positive relationship. While you are sick on the bed, I know you don't want to talk to too many people. There must be 2-3 persons who are reference people in your life that you can share with. I can manage a group of young people. They say when they're in trouble, they ghost people. Don't ghost people. Don't ghost those who will help you. You know, ghosting is, they tell you they zone out. As a patient, you can't zone out on your therapist. You must tell how you are feeling. So have 1 or 2, 3 persons in your life that you always talk to. Then take a helping hand. Don't ever reject help, especially when it's coming from those who can help. Then don't be afraid of changes. Changes do happen. Oh, you're beautiful today, but tomorrow something suddenly happens. I mean, those things can happen. And even in the midst of the pain and the wound, you must be able to enjoy the beautiful things of life. So if you are lying down on the bed with some form of pain, have you tried watching a game of football while you're there? Have you tried chatting with the people that matter to you? Have you tried listening to the latest songs? If you are a song lover, if you are a movie lover, while you are there, don't put your life on hold. Enjoy the beautiful things of life. Then find flow and be engaged. You know, in your, you know, when someone is riding, what do I mean by finding flow? You are riding a bicycle. At the beginning, when you are riding, you wobble. But when you continue to press on, you get to stabilize till you become a pro. So in your wound management as a patient, at the beginning, you just may not understand the situation, but just go along till you find a balance and work on getting yourself back together again. And then find hope and keep the faith alive. If you lose your leg, you haven't lost everything. Consider those who were even born with a limb. or fingers or whatever it's worth, and they still make something good out of their lives. And finally, just want to say this: the psychological effects of wounds have severe impact on the quality of life. So these effects does not only influence the occurrence of further wounds. In this psychological effect, they can lead to other wounds, either physical or even emotional, but it can also aggravate existing wounds and affect the ability to heal, resulting in further psychological challenge. So this is the vicious circle that I was talking about, that every healthcare professional must understand. And with this in mind, one can better help. Thank you very much for listening. Where there is a wound, there is a way to healing. God bless us all.
Amen. Thank you so much, Olabode. That was fantastic. Thank you. That was awesome. Thank you so much. We will go straight to questions because there's been quite a few in the chat. As I said, please just stop sharing for me so that we can see everyone. Great. Thank you. Yes. So as I said, we're all learning together. We're all sharing. So when it comes to questions and comments, please feel free to share. We have healthcare professionals from around the world. We can all contribute and learn from each other and help each other. So, Bumi, over to you. I know you've got the questions collated, and let's start dealing with them.
Absolutely.
Yeah.
Can we add all the speakers on so at least everyone can
Yes,
be part
please.
of that?
Matron and Prof, please could you put your video on so I can spotlight to you so that we can
So
go.
the first question is, how do you help a stage 4 DM foot PT with septic wound and financially poor to care for herself? What do you do? So I think someone has a stage 4 wound with septic wound and they're financially poor to care for themselves. So what do you do?
Matron, do you want to take that? Just a mute for me, thank you.
You're muted now.
Go for it, we can hear you now.
She said how to help a financially poor patient with stage 4
septic wound.
Right. Financially, that's a bit of a challenge for a health worker. How many of those patients can we help? Usually, for some patients in the units that need financial help, apart from those that have wounds that we deal with, we try as much as possible to contribute within ourselves at the particular time we see the patient. And then we appeal to some patients that we see that are a bit of financially buoyant to help them whenever they come to the clinic. There's little we can do financially for such patients. We usually advise them to seek for help from their relatives, those that are close to them. And then sometimes when they come to the clinic, we try to waive off the fees they pay for wound dressing. We try to, like I said, contribute within ourselves too. Okay, the patient needs a normal saline, we try and provide that. The patient needs a sort of cream or something, we try and mobilize within ourselves. Let's contribute and help the patient as at the time we see the patient. There's little or nothing we can do financially for such patients. We cannot start what we cannot finish. So at the time we see them, we try and take away a bit of the burden of them. We will try to provide the lotions and things they need and waive off the fees they need to pay at the time they come to the clinic. I think that's all we try to do in our own capacity.
Thank you so much. I've got a next question, then I'm gonna call Senior Nurse Abiola Ogunlewe, if you're still here to ask your question. The next one
No,
is,
hold on. She's one of the speakers.
I'm sorry. Yes, sorry. That question was actually posed to her, but this one
Okay,
was
okay.
actually posed to Professor Olufemi Fasomade, but others can answer as well. It says, my question is on data and management of diabetes in Nigeria. How prevalent is diabetes? What are the challenges managing it in Nigeria, and how can these challenges be addressed?
I don't know if Prof is able to. Yeah.
So concerning diabetes in Nigeria, it is a very prevalent problem. In urban cities, we have usually 1 in 10 adults having diabetes, and most of them are not diagnosed. We actually have somewhere between 5 to 8 million people that have diabetes in Nigeria. But we are not really talking of diabetes per se today. We are talking about the ulcers, of which we have heard diabetes is a major cause. But as you heard from my other co-speakers, it is not only diabetes that causes a chronic wound. Diabetes does it, sickle cell disease does it, Hansen's disease does so, venous ulcers, cancers, osteomyelitis. There are many things that cause chronic ulcers. I was just using my own position as a diabetologist to highlight some of the problems that I've seen. Someone mentioned about people with stage 4 diabetes, foot ulcers. How do you manage them with all the financial problems? The truth is that there is really no way, but you just have to look for the funds, because by the time you need a major surgery for a diabetes-related ulcer, we are going to be talking about minimum of ₦500,000 to about 2 million naira. And I'm sure if you're outside the country, you'll be talking about somewhere between 20 to 40,000 pounds if the person is paying from out of pocket. So it is a big challenge. And what people do is that they rely on support groups. In Nigeria, there is a Diabetes Association of Nigeria, and then there are a few other NGOs or crowdfunding that might come to a person's aid, which is why we are trying to emphasize prevention. Prevention is much cheaper, more convenient, and cost effective.
Thank you so much, sir, for that. We've got a lot of financial constraint questions, so I'm not going to ask again on that one, because someone did put on the chat that I think NGOs as well can help. So I think that should answer that, and I know that we have already answered one before. Another one is, one of the ways to mitigate the mental health stigma, as it were, is for clinical psychologists or trained CHUs to be attached to the wound care area. Oh, I think this is just talking. Another one is, I want to know if such wounds can heal permanently, and what strategies and ways do you lift this already? So I think that is to Nurse Abiola or anyone.
Okay. So, Metron Abiola, you can talk, please.
Matron, go for it.
Can I have the question again?
Can such wounds that you've shown, can it be healed permanently?
That is a very difficult question to answer. Well, I believe fervently in the power of God. So I cannot say categorically that the wound cannot heal, but from a medical perspective, the prognosis is poor for those kind of wounds. A wound that you have been dressing for the past 3-4 years, 10, 12 years, I cannot say categorically that the wound can heal. They have their bad days and they have their good days. The good days, you think that the wound is healing, and finally you're making progress. And then they'll go right back to how the wound was initially. But by and large, I've seen wounds that healed after a long while. So I can say for maybe 20% or 30% of such wounds can be healed permanently. But for the ones I've encountered, I think the prognosis is very poor.
Add to what Matron Abiola said, it depends on what the underlying cause of the wound is. If you are able to address the underlying problem, then you can get a wound to heal. For instance, if it's due to poor blood supply, you can improve the blood supply. You just might get it to heal permanently. If it's due to poor diabetes control, if you can control it, you might get it to heal. Well, nowadays, some bone marrow transplant and you can dilute the hemoglobin S, and the person now has sufficient hemoglobin A in the system, you just might get the wound to heal. So there are various factors that will determine whether the wound heals or not. But it is to find out the underlying cause and see whether you can correct it. That will determine the healing ability of the wound.
Thank you so much. Essay and Ajayi Akejelu, if you can put your hands up, please, and I can call you. I think it's so much easier. The last question that I've got on the chat is, what strategies and ways do you lift those already so downtrodden by the burden and stigma of non-healing ulcers?
Well, thank you very much for that question. I think I should go in here. Like I have mentioned earlier, for everybody and every patient actually needs some form of encouragement. For those whose wounds have refused to heal, we must make the patient understand that, wound care or the stance to healing is not an all or nothing process. Because there are people, when they go for care, they assume that this hand has to go back to how it used to be. It begins from there. And at the end of the day, when they discover that even healing is going on, and it doesn't have to go back to how it used to be, they become more disturbed. So it is important that they are spoken to. Is not an all or nothing principle. Even if it does not go back to how you used to be or how it used to be, the fact that you are able to function and improve or move on in your area or other areas of life is very, very much important. And then while wounds are not healing, we must encourage people to actually prioritize their care. Self-care, self-compassion. It could go on for long, but whether you like it or not, if you do what you're being asked to do medically, you will see changes. Then many a times there could be setback, like I mentioned to you earlier. I once had somebody very close to me, a brother in the hospital, who had an operation, and the doctors and nurses were on strike. It looks pretty much like a setback. But at the point, we didn't see it as, oh, this is the end, he is going to die. We saw it as even part of the process. And there were certain other things we had to do on our own. And then, of course, we're also patient. If we are patient, sometimes we tell patients to be patient, but we need to say it genuinely and then persistent with healing. You are already in the hospital. Let those who want to take care of you, let them take care of you. And then in healing, wounds healing, like some of the wounds we have seen today, it takes baby steps. You may not see the effects immediately, but we must encourage them that they should take one step at a time. And then we must not set unrealistic goals for ourselves. Because there are people who come in, they will tell you, oh, this has to go back to, the way he used to be. If it doesn't, would you put your life on hold or would you rather move on? So for anyone, and the pains are not healing, the wounds is not healing, there are so many things we need to check. Their psychological state is important, and all the other things we have mentioned. Are they getting enough rest? Are they sleeping enough? Do they get support from the family members? And even their diet, which Prof has mentioned. What do they eat? Does it support their progress or is impeding their progress? So these are some of the things we should pay attention to. Thank you. And for those who need help, let's refer them. Oh, you've been on this forever. There are some patients who even get cranky and angry as a result of the anxiety. Sometimes if you are not careful, your patients will fight you. You know, you're caring for somebody, your brother or your sister, they may fight you because they may even begin to see as if you are their enemies. You're keeping me here for too long. I've been on this bed forever. Can we just try other means? And then even in our country, Nigeria, there are other sides. People will tell you, why don't you look at the natural side of things? I mean, why? I mean, do you just want to remain in this hospital? So there are so many things going on in their head. But we have to encourage people to be focused on their healing and then their personal well-being, even when they get healing. I've seen people who get healing and they move on to live their life and they show people the scar. Oh, this is what happened. And they are even able to encourage other people. That's what we call post-traumatic growth. You say, oh, I've been in the hospital for a year. I've been able to take care of this. For those who are going through it, these are the things that you can do. We all need support, the patients, and even those who are helping. So let's continue to support one another. Thank you.
Thank you so much, Reverend Daramola. I'm going to have Essay. Essay, I've asked you to unmute yourself. Then after that, I would have Ajayi to ask a question. Yes, Essay.
Okay, still on the psychological, do we have support systems, you know, for people going through psychological and psychosocial problems? And then how do we begin to address stigma surrounding mental health in Nigeria? Thank you.
Who wants to go first? If you can unmute.
Okay, I've been asked to unmute again. Yeah, that support system is one of the ways through which we can actually mitigate the stigma that comes with it. You know, when people come together, they have, you know, that comfort. People discuss how they feel. I'm sure there are so many. I'm not exactly sure if there's a support group for people who have wounds in Nigeria. But I know that there are, for diabetics, if Prof would let us know. You know, there are other, I've had to deal with some other things, even as much as even grief. There are people who come together, they share their experiences. And that way, people now realize that, oh, there are other people who are going through the same thing that I'm going through. So this support system is actually a way of actually, you know, I mean, it's an opportunity or a place to help with the stigma, if you know what I mean. But I'm not sure in Nigeria if we have any of some that is specific to either chronic wounds or whichever way. But I'm sure that, of course, there are lots of groups on diabetics, grief, you know, and all other matters. I'm not specifically sure if there's one that comes together. But of course, this discussion we are having can even help. The fact that people are talking about this. While I posted this on my status last week, somebody said, hey, I just have to attend this. And the person is on the call. Not sure if he's still on, because he says he has a dad that is supporting his dad, and it's so difficult. I said, oh, fine, join in. So for people like that, they will get encouragement. And that's why I thank Encapsulate Health for what they're doing now. And for each and every one of us too, who have the opportunity to be able to start up something like this, we should also help. Thank you.
Matron, do you want to add anything?
For patients dealing with chronic wounds, I think the family system could be a good support system for them. Try as much as possible to encourage the family to be involved in their care. Whenever you see them at the clinic, you try and encourage them to continue with the care financially. And then most times, like the patients are usually for the girl with the sickle cell leg ulcer. Whenever she comes to the site, alone most times. And then there was a day she came with her mom. I think the mother came and followed her to ask why the wound was not healing. And then she flared up and told the mom that, are you not the cause of my problem and all that? So I think the family too could be a good support system for them. We tried to encourage the mother. The mother started crying and apologizing to the girl that, okay, I know I'm the cause of your predicament. And as much as possible, we try to encourage their support. So whenever they come to them, when we are doing the wound dressing, we invite them to see the progress of the wound so that they don't think that coming to the clinic with this patient, is it fruitful or unfruitful? So I think the families could be a good support system if they are incorporated into the patient's care at each time they come to the clinic.
Thank you so much for that. The next person is Ajayi Akejelu. I've asked you to unmute yourself, please, if you can. Thank you.
Ajayi, can you unmute yourself?
Hello, ma.
Yes.
Hello, ma.
Go for it.
Okay.
We can hear you, Ajayi. Go on.
Nice. Okay. Presentation is very, very nice. But I just want to ask a question. Is there any source surveillance toward this wound care and management? Hello.
I think our question is there any surveillance towards this wound clinic management? Yeah. Anybody? Health surveillance?
Is there any surveillance in terms of wound management? Does anyone know if there's any healthcare professionals on there who are aware of this? Please raise your hand and contribute. If we know of any surveillance of wounds in not just Nigeria, in Africa, if there's any such system in surveillance of wounds. Anyone? Or wound management? If we have anyone who knows anything about that. Oh, doesn't look like it, but if it comes to you, just pop it in the chat. Let's go to the next question, please. Maybe someone will.
Okay, the next one is...
I don't think there is any surveillance for wound. It's not a notifiable condition, except if the wound is due to Hansen's disease.
Okay. Thank you, Prof. All right. Dr. Herrera is saying, Ajayi, could you clarify your question? What do you mean by surveillance?
Maybe you can put it in the chat.
Yeah,
we'll come back
put
to
it in the chat. I will come back to it. Yeah. Next one.
Pastor Liz Emmanuel, please. I've asked you to unmute. I think I did see a question. Okay, while we're waiting on that, Josephine, you've got your hands up. Josephine? Yeah, thank you.
Okay. Oh, can you hear me now?
Yes.
Okay. I just want to say thank you for all this good work. Hopefully it will get us somewhere, especially in Nigeria. But I just want to draw your attention to some. So I think somebody asked a question. So the doctor, is it the professor, answered, but I wasn't fully clear because I thought the person was asked. Well, it was a pharmacist that asked that question. I think she was kind of saying how is the way, to prevent this the signs and to prevent the ulcer developing in the first place, because prevention is better than cure. I know they've mentioned some areas. Somebody asked a question from Houston about how to prevent developing arterial ulcer, and it was answered. I will say one of the preventions is actually, let's go to the grassroots. The way we look after our hair, and our scalp. We always deny the legs and the feet of the kind of care we give to other parts of our body. So if people who are good in developing jingles in Nigeria, they can, because there are many people who are into jokes, and we are very good, we are gifted with jokes and jingles in Nigeria. If the association of the wound, if there's anything like that, the association of the wound care people, or whatever name we want to call them, or even the dermatology clinic, they can put some pictures or jingles or education, organize some educational rally. Like I had worked in NGO when I was in Nigeria. I know how we used to organize some rallies to educate the, I was working with Stop It then. We are into educating the AIDS patients and educating the public in motor parks. Our health care units were always in motor parks. So something like that, I'm just giving it as an example. So educate the public. Like the last speaker was, all the psychological things he actually said will be very, very useful in educating the patients themselves and their families. So like I said, developing such things like how to, you care for your hair. Some men go to barber every week or every fortnight. They take care of their beds, shave and all those things, look after their face. But the legs are always, neglected. And these are the legs that
Okay, I think
I'm not sure if, I think we have lost her. I think, I'm not sure, maybe trying to say that these are the legs that we use to do everything that we need to do. But I'm not sure, but I think that's where she was trying to go to. So maybe does anyone have anything to add to what she's saying, or we've got, she can come back. If you're here, Matt, just put your hands up and then we can call you back. I can't seem to see her.
Okay.
Okay, so I think, did I see Mrs. Babalola? Put your hands up. Yeah, I did see you. I've asked you to unmute, ma. And then we can always come back to her when she's back. Miss Elizabeth Babalola, please. Yes, thank you.
Thank you so much for this education. I'm interested in that jingle she was talking about concerning an association. As far as Africa is concerned, we don't have a wound association, but through the grace of God, a year ago, we launched one, which the processing of registration is on and is almost completed. I think one of our assignments will be this jingle, because the issue of diabetic foot ulcer is a big problem. In the last 4 weeks, we've lost 3 patients that they had amputation and they died, all following septicemia. They went for tradomedical because of financial constraint. They could not afford their care. They went for something cheaper and came back with sepsis and with a grade 4 diabetic ulcer. And they ended up amputating, but yet we could not save their life. We've had other cases too, that even through the multidisciplinary approach, we were able to survive those limbs from amputation. So I think it's a good opportunity to really share to the public awareness so that prevention will really be cheaper than cure. Thank you.
Thank you so much, Mrs. Babalola. That's fantastic. And before I call on Abosede Adebi Abi, I've got a question from Onyeka. Onyeka, do you want to ask your question? I have asked you to unmute yourself. Oh, let me just read it out. It says, thank you very much for the very educative lecture. What is the place of nutritional support in wound healing and the effect of vitamins to also support wound healing?
All right. Matron, do you want to take that? or Prof? I can't see Prof at the moment.
In our elementary teachings, we all know food groups: carbohydrates, proteins, fats and oils. So we've been made to understand that proteins are the building blocks. And so the place of nutrition cannot be overemphasized in wound healing. Place of multivitamins to supplements cannot be overemphasized. We see that for some patients, if you place them on a high protein diet, for patients that go through surgery and the wound is not healing, they are usually placed on a high protein diet. We know that protein are the building blocks. And so a patient that eats a lot of proteins will help in the wound healing process to form collagens or fibrin and all that. And then for your, we say that some vitamins to play a role in wound healing, like a vitamin C and the others, they play a very good role in wound healing. So for those that have wounds that refuse to heal, they're encouraged to eat well, eat a lot of proteins, vitamins, and minerals, and all that. It helps to replace the lost tissues that occur during a wound happening. And so a place of nutrition cannot be overemphasized when we tell patients a lot of eggs, beans, poultry, meats will be incorporated into their diets for those that can afford it. Of course, finances too will play a role if such patients cannot afford all these proteinous foods. And they could go for lower sources of protein like beans, legumes, and all that. So I think nutrition, a place of nutrition cannot be removed in wound healing.
Thank you very much. The next person is Abosede Adebiyi Abi. I think she was the one speaking earlier before the line went off. I've asked you to unmute. If you can just let us have your question, ma'am.
Yeah, hello. Abosede Adebiyi is a pharmacist, retired community pharmacist. I'm in US. Right now, I'm a caregiver, professional consultant, and trainer. I'm also an immunization pharmacist. While I was in Nigeria, I had a pharmacy that I managed in front of the Solo General Hospital, and I was privileged to see a lot of diabetic patients, some with a lot of wounds. And I started something with a friend who then was a nurse. She will come in, help me to dress the patient's wounds, and we started using honey. And by using honey, after cleaning with Jusol or something, she started using honey to dress the wounds, and we recorded a lot of improvements. Some were healed completely. Then we encouraged them to change their diet, a little bit of modification in the diet. That was why I put something on the other time that's low glycemic index foods that are that are low in sugar. Of course, we know that fruits and vegetables are carbohydrates too, but low glycemic index food, carbohydrates. So we encourage them to eat more of fruits that are low in sugar. We take them away from soft pawpaw. They have to eat the type of pawpaw that's still a little bit green, like greenish yellow, that when they eat it, it will be making some sound in the mouth. If they can afford, then no more pineapple, because pineapple is high in sugar. We encourage them, if they can afford, taking apples and avocado pear. We call that pear in Nigeria. Then beans, a lot of beans. A lot of beans helps, and some of them we modified something like, I missed soybeans, with corn, with maize, to modify their intake of carbohydrates, and it helped them to get healed. So modifying the food and sending them to nutritionists sure help them with the wound healing. Then some of them were taking soy milk. I taught them how to make soy milk at home. I will invite nutritionists to my pharmacy to show them how to do soy milk and all that, and it really helped. Then we took them away from white maize like ugi. They were mostly on the millet type of kwababa, and it really helped. And also encourage them to eat a lot of nuts, like peanuts, cashew nuts. All those help them a lot. Thank you. That's my contribution. I was invited to this program by pharmacist Falashadi Lawal, Victory Pharmacy in Festac. Thank you. That's my contribution.
Thank you so much, ma'am. And yes, thank you, pharmacist Folashade Lawal. We appreciate you, ma'am. The next person is Josephine. Then after that, we have Dr. Agun, then Dr. Adeyemi. Thank you. Josephine, if you can just ask your question, please.
Hello. Hello, can you
We
hear
can
me?
hear you. Yes, we can.
Okay, sorry. I didn't know I went off actually. Hello? Hello?
We can hear you, ma'am. We can hear you.
Okay, I didn't know
Yes.
I was off.
Yeah, you were off for a
Another
while.
thing I wanted to add is that with the jingle and educating the public, it will also help this aspect of stigma that we have in Nigeria. I know civilization is coming up now, but in those days, it is the people who have, are you still hearing me? Hello?
Yes, we can. Yes, we
Yeah.
can.
People who have all this chronic ulcer, the society always, they have that's the serious stigma of saying that probably they've done some bad thing, or they themselves will attribute it, and the family, they attribute it to witchcraft, that people are disturbing them, somebody did it to them. I know of somebody who said since she borrowed her friend her shoe to wear, and she returned it, that's when she developed the ulcer that wasn't going, and actually nursed the lady, the woman. So she had a chronic ulcer. So she was telling us the story of how she borrowed her shoe out. So there's this belief. So if this going to the grassroots to educate, we really take care of many, we kind of educate the public and take care of their belief, So that's my kind of small contribution.
Thank you so much. Mm-hmm. Can I have Dr. Agun, please? Dr. Agun, I've asked you to unmute, sir. And then we have Dr. Adeyemi afterwards. Because I can see your question, but I don't think it's complete. One of the ways to mitigate the mental health stigma, as it were, is for a clinical. I think that's all I can see. It's not complete here. But while we're waiting for you, let's go to Dr. Adeyemi, please, sir. Thank you.
Good evening here in Nigeria. Can you hear me?
Yes, good evening.
Evening.
Okay, I want to thank you, the organizers, for this wonderful topic and the group of presenters who have been chosen to speak on this topic. It's timely, and unfortunately, I use that in the sense of the fact that those who are supposed to have full participation, the core medical workers, I believe, most of them are here, unfortunately, because of this aid their practice and help in the process of wound healing. I want to thank my father in the Lord who invited me here and who encouraged me to speak. I work with the state government and I'm in the government medical practice. And on the average, I come across about 500 to 1,500 individuals a week, sorry, who come in for various care in the hospitals. Incidentally, this is the second lecture I'm listening to by Professor Fasamadi today. He was on another program earlier this morning, and I was also there. And the matron from Luther spoke and gave the case presentations was fantastic. Those were, yes, timely, on the spot, and true life scenarios. Now, without wasting too much time, I'd like to give my own contribution. I remember a couple of years ago, I was in a meeting and we were giving this example of a cantankerous woman in the society. She was difficult to live with, difficult to have around, and nobody could just be comfortable around her. She ruled the day, she ruled the environment, she ruled everywhere she was. She lived alone. Incident along life, she developed diabetes and then developed the complications of the diabetic foot problem. She needed to have it amputated. She was taken to the hospital and her legs were removed. But the medical workers found out that she refused to go home post-healing. She was there for the first month after the wounds were fully healed, second month, and they were uncomfortable. Madam, you can't stay here. You have to go back home. She refused and it became a problem. Eventually, she had to be forcefully taken out of the hospital to her home after spending about 6 months post-wound healing in the hospital. And they found out that she committed suicide within 2 weeks of getting back home. So yes, wound healing, there is always a psychological component to all wounds, which sometimes we recognize and many times we do not recognize or see because we are not trained to deal with that or to even recognize it. And so many times the healthcare worker goes about his work and it's all strictly sorry, that's his say 99, breathing, take care of this. But the other aspect of the individual is not taken into consideration at all. And so many people come to the hospitals and are looking for care. And of course, what Reverend Daramola said hit the nail on the head. There are many aspects to the individual, but many times in the hospitals or in the society, only one aspect is focused on, and that's the physical components. Essentially, today I was reading about the neurosurgeon in the UK that committed suicide. In our doctors group chat in the hospital, a couple of doctors were commenting that this issue transcends and affects so many of us, and we're all smiling at ourselves. And it's hit the nail on the head because I happen to know that a lot of healthcare workers are abusing substances to heal one form of wounds or the other, which goes beyond the physical. So without going or saying too much, I want to thank you for this wonderful topic, for this wonderful presentation, and for the group of wonderful lecturers you have brought. And I hope that you will have another opportunity to expand it to core healthcare workers and integrate with them such that this psychological aspect is also, let me digress again. I work in the suburbs, way out of town. And we have noticed that since, is it last year or year before last, at least one young person per day is being admitted in the hospital for attempted suicide. We don't know how many have been successful. And unfortunately, many times, because not all core healthcare workers are well trained, we lose them. There is no integration with the psychiatrists or the psychologists because attempted suicide, okay, so stabilize it medically, treat it medically, and you don't take care of that wound that caused this attempt. So thank you. And I want to say God bless and more grace to your elbows.
Thank you so much, Dr. Adeyemi. Dr. Adeyemi, please send me your details. And can I just for the benefit of our audience, when you say the core health workers, could you just be more specific about who you mean, please?
All right. Those who are primarily into clinical practice, doctors, the nurses, the pharmacists. They meet with thousands of people every week, every month. And a lot of the people that they meet with have psychological wounds. I'll give you another example. I remember I was working in the hospital one day and I saw this lady and she was looking so depressed. She had no physical wounds. So like, madam, what's the problem? And then she starts to blabber and I said, relax, sit down. You're here for the clinic. You're here for your hypertension clinic review. And I said, madam, you are not going to die. The sigh of relief was so audible. I said, doctor, when I was given, and incidentally, in the healthcare industry, we don't see people as individuals. We see them as labels. Like I say, when you go to the hospital, go to get a label. That diabetic foot came last week. That hyperthyroidism came. That hypertensive encephalopathy. So we get the labels, and then we will further inflict more injury and harm and become professionally, emotionally disconnected from the true individual. Thank you, ma.
Thank you so much for that. Thank you. It is a big issue. Well, this program is aimed at the core health workers, to be honest. So that's who we're targeting. I will continue to do what we can.
I've got Dr. Innocent Oko-Awo. If you just, yeah. Dr. Innocent. And I've got, okay, yeah, he's unmuted now. Can you please pass on your comments, sir?
Okay. Well, first, I would like to show gratitude to the organizers there. It's a wonderful opportunity here. I practice.
You're breaking, Doctor. You're breaking, Dr. Innocent.
Okay. Am I audible now?
Yes.
Okay. First, I'll start by I'm really honored to be here, and it's been quite informative. I manage a lot of patients with diabetic foot ulcers, sickle cell patients with chronic ulcers, and so it was truly a delight that I am in the audience, and I think the person that invited me, I don't know whether he realizes my link with Professor Fasomade. So the moment she said it was Fasomade, and then of course I just had to be here. And then of course, usually it's quite informative. I would like to just talk in the same line with the last doctor that I'll give an example, almost like what she said. It was a patient with a fungating breast ulcer. Of course, it turned out to be stage 4 breast cancer, and she had a stench all around her. And I was just joking with her, and I said, okay, fine. She had 3 sons. We're talking. So she had 3 sons. And I said, oh, fine. Do you know you're going to have 6 children at the end of the day? And she went, what do you mean? I said, when your 3 sons get married, you're going to have 3 daughters. And your 3 sons plus 3 daughters will make 6. And then her husband told her, guess what? Your doctor just gave a prophetic pronouncement that you're going to be alive to attend your children's wedding. And the glow on her face was unimaginable. This is the same person that had been running away from surgery for more than 2 years. And in 2 weeks, we had done her bilateral mastectomy, and she's enjoying herself. It was just that difference. Treating the patient as an individual, not as a statistic. That's what my colleague mentioned. But it's also not easy because we have so much on our hands. We have so much to do. But as long as we recognize that, I guess it's in our training, really. We're two physiology, anatomy, biochemistry, anatomy, pharmacology. That's all. But there's much to it. I would also talk about the stigma of referring to a psychiatrist or a psychologist. I think it's the way we do the referral. If we tell a patient there is an aspect of your illness that needs someone else to deal with, since we already know that, there is a stigma when you mention psychiatrist or psychologist. We just tell the person,
I can't hear him anymore.
just the way we would, just the way Professor Hassan, an aspect of your illness that needs to be managed, you need trust us so much. Doctor, okay, fine. I'm sure you add value to your treatment. So I guess the way we refer may also affect how the patients accept our referral. But on top of that, I'm with you guys all the way. Anytime, because I also participate in some wound care projects by some US NGOs. So, and this is one beautiful aspect that we haven't even talked about. And so I'm grateful to be here, and I'm thankful to all the organizers and to the participants.
Thank you so much, Dr. Innocent. Please send me your details. I definitely will be in touch because I believe in collaboration and it's the way forward. In the guise of a collaboration and MDT, I wanted Mrs. Lawal. She's a pharmacist, community pharmacist. I'm sure a lot of us on here know her. Just for her to make a comment about the role of pharmacists in what we've all been talking about. Mrs. Lawal, over to you. I did say I was going to call you. Just to make a comment about that. If you could just unmute yourself, please.
Okay, good afternoon. Yeah, afternoon there. Am I right? I'm not there now, so I'm far away. Yeah, it's been a very wonderful day and lots to learn. And I was just thinking about the roles that we as pharmacists can play in all of this, especially being first point of call, because we all agree that prevention is the key. And we see these patients a lot. So if at the point we see them, we look out for patients that are at risk and help them to understand why they're at risk and what to do, and give them the necessary support. We might go a long way. I'm sure we'll go a long way in averting many of these sad stories that we have had today. Besides that too, we can also help those already victims, give them the support that they need. Many of us do home visits and all that. We do medication use review with them, and that affords us opportunity to help them understand what they are passing through. I recall some years ago, one of my pharmacists came to me to say a particular elderly woman had a sore on her leg and she was diabetic, and everything is said about referral. She just said, no, when I go abroad, I will see my doctor. So she had to invite me in. And the first thing I did, I looked at her. And then I just admired her. I told her she was so beautiful, and she was looking 20 years younger than I. And that was the melting point. She was not ready for anything that we would do. And then I was able to refer her, and she went. And the pharmacist was like, what did you do? I said, I studied her. I saw that she had given up on herself and she needed that encouragement. So sometimes we just have to come in more strongly to help these patients. it's a nice day, and I've enjoyed being part of this. Thank you.
Thank you. Thank you so much. Thank you so much. Do we have any more questions or comments? Like I said, we're all learning here. We have healthcare professionals from different parts of the world. Your contribution, your comment is helping someone else in their development. So please feel free. We will finish in the next 5 or 10 minutes.
I think we have Chika so that we don't lose track of her. She had a comment or question. Chika, can you unmute yourself? And I think after that we can have a Abosede. Chika, yeah.
Yeah, good evening. Good evening.
Good evening.
Hi, I'm based in UK, and you know, I found what you guys are talking about very interesting. You're so right. Trauma can do a lot of things. My mum actually committed suicide 20 years ago, but she was not your typical candidate, if you know what I mean. She was not, you know, she was a very strong, tenacious Igbo woman. And it was a shock to everybody's system when she did what she did. But just going by the question about, you know, talking about substance abuse. So would you say the substance abuse is for UK medical, or is it across the globe?
I think was it Dr. Adeyemi that mentioned about substance abuse?
Yes, yeah.
Dr. Adeyemi, do you want to respond to that, please?
Sorry, I missed that as part of the question. Substance abuse, what aspects?
So the question was, so the substance abuse, the high rate of substance abuse, is that among just healthcare professionals in the UK, or were you referring to Nigeria, or was that worldwide?
Nigeria. Okay. I was referring to Nigeria, and you know, people are wonderful actors, and everyone tries to cover up your wounds. It's natural. So until recently, I never got to realize that we have missed all the telltale signs of those having substance abuse among healthcare workers working within and around us. It's okay for one of them. I'll use a she because she got to a place where she had complications based on the fact that she had ulcerations from having to inject herself so many times a day. And by the time we sent her, okay, you have to be on this medication, you're having pains based on this disease condition. And the nurse told me in confidence that, Dr. Adeyemi, there is nowhere on her body we can give an IM injection. Everything is fibrosed or has wounds. And that's when you say, please give her painkiller, she says she's taking so much morphine and diazepam together, and we're alarmed. Recently got to know about another doctor I've been hearing about so many times. There's so many of them, but I'm giving us examples. We share word quotes, we share resources. So sometimes you pick up this word quote and you just suddenly realize that you have so many vials of opioids in the used vials. I'm like, and you guys, who is giving injections in the call room? And then stories start coming out of, I said, I've noticed that this person, this doctor, this person is always wearing long sleeves, even in scrubs and in sweltering heat conditions. I'm like, wow. And then you start listening closely to conversations or their remarks and realize that they're actually calling out for help.
Yes.
But many times we are not equipped to. And so lots of the time it slips through our fingers. So yes, you say, okay, like Dr. Kwawo said, the way and manner you tell the person, the individual, go and see this person based on this referral condition, will either help the person to go or impede the person's efforts to go. And so a few of them, I remember that where he was having serious issues with the administration, senior colleagues had to intervene and tell him, all right, please go and see the psychiatrist in this hospital. As I speak to you, 8 months down the line, this individual has not gone. And they know that there's something wrong all over his life, all over his working conditions and his interactions with patients. So, like I said, we need more of this, and we need to be fully equipped to be able to deal with this substance abuse among healthcare workers, which is slipping through our fingers.
Thank you very much for that. Chika, does that answer your question? I hope it just let us know in the chat. All right, Bumi. I can't hear you.
Oh, sorry. Can you hear me now?
Yes.
Thank you so much for that. And thank you, Chika, for raising that. The next person is Abosede Adebiyi Abi. I've asked you to unmute as well. And then after that will be Adewale Ola Digbolu.
Thank you. Thank you once again. I'm a pharmacist in US, retired but still practicing as a professional caregiver, consultant, and trainer. And before I left community practice, I delved into psychiatric pharmacy as well. Just to buttress what the last speaker said, Dr. Adeyemi, a lot of healthcare workers are into drug abuse. There was a particular psychiatric doctor that I worked with. He actually was the CMD of that particular hospital. And I found out that he will prescribe ADHD, the medication for attention deficit, for young adults, like teens. The dose for adults. Okay. And he will make sure that we supply to the inpatient pharmacy whenever they are on admission. And he was working in collaboration with another nurse. So when we supply the thing, they will now cut that particular medication into two. He will take away the half with the collaboration of the departmental head of that unit, and they will give the patient half. Of course, I didn't know that when I came in, and I was a pharmacist on duty that Saturday, and I realized what happened. So I realized that he overprescribed the medication, and I called him before dispensing the medication that dosage was just too high for that particular patient. And he said, oh, I've been practicing as a psychiatric pharmacist, I'm a consultant medical doctor for over 30 years. I've been prescribing it that way and all that. So we went into an argument. And as a pharmacist, I have the right to refuse to dispense that particular medication. I wasn't the head of my department, so I had to call my head. He was off duty that day. I called and I said, hold it, don't dispense it. We will discuss about it on Monday. So now, so what will happen to that particular patient? So I was told that normally they have some in the unit that they could give the patient. So I went there to check, and I now realized that they had cut some of the medications into half. Of course, they haven't been given the patient, like the patient should take one in the morning, one in the evening. They will only give the patient the one in the morning, and then the doctor will take away the evening one. So the doctor and the nurse were using this, and apart from the ADHD medications, I realized that some of them were going away with the Valiums. So I did my investigation with my HOD. We found out what happened. Of course, the CMD was fired, and you know how they carry guns over here and all that. So I had to leave and went back into community pharmacy. And even within the community pharmacy practice, I realized that there were some technicians and some other pharmacists on duty with me that were stealing some of the medications, Viagra, and mostly some of the medications that can keep the oxycodone, Percocet, and all that. So a lot of healthcare workers are into substance abuse, not only cocaine. So we need more of such a program, like to discuss about substance abuse among healthcare workers. Some of them, it had even led them to committing suicide. So we need to encourage ourselves, especially during this pandemic. A lot of healthcare workers committed suicide. Some have even resigned and they are no more working. They are at home. Some went into another profession entirely that they couldn't take, the stress of seeing so many people dying and they couldn't help.
Thank you so much for sharing that.
Also,
thank you so much.
Talking about the food care, somebody mentioned food care.
Oops, I don't know what's happened.
I think
Okay, let's go to
I'll
the
go to the next person.
yeah. I don't know what's happening.
Adewale Oladigbolu, can we please quickly? Because of time, let's keep it short and simple. Thank you. Quickly, please, Adewale Oladigbolu.
All right, thank you so much. My name is Wale Oladigolo. I'm a pharmacist and I practice in Nigeria. I'm the national chairman for Association of Community Pharmacists of Nigeria. I joined midway, but quite an interesting discussion, and I really appreciate the people who put this together. I pray that we'll have it more often for the purpose of educating even the healthcare professionals. Having said that, I think for community pharmacists in Nigeria, we see quite a lot of people. One of the bottom lines that I would like you to point your attention to is the resources available for taking care of these people. When you talk about diabetic foot ulcers and all sorts, even people who are very diabetic and who are diabetic and are not unaware of what they need to do to prepare their feet. So we give such education. But when it comes to diabetic foot ulcer, the major problem I've seen in my practice is people who refuse to complete their referrals because they don't just have the money. So when we take care of what we need to do, we should also talk of the health structure, the health system structure to support those things that we need to do. I've been asking, for example, of the phone numbers and the directories of physicians in private practice in Nigeria. I haven't got that. So even when you have to do referrals and you have to check the referrals that you are doing, whether it's complete or not, you can see that the structure on the ground does not support that. And for people who are on this call, on the last note, I would like to ask that we all drop our phone numbers and exchange contacts so that we can continue this conversation even after the schedule. Thank you.
Thank you very
so
much. Yes.
Mr. Adewale.
Mr. Adewale, you drop your contacts too. Thank you.
So just to let everyone know that this is something that we do periodically. I mean, it might be somebody's first time of joining, but we do this regularly. But in order for us to, notify you, it's important that you follow us on our social media pages, which is at Encapsulate Health. We have one on Facebook, we have one on Instagram, and we also have the past videos on YouTube. So you can always go back and watch the ones that we have. And like you rightly said, Mr. Adewale, everyone, please do drop your contact details. It would be good. We have the visionary here will be able to collate something from there. Obviously, also looking at GDPR or data protection. Can I have Gerald, please? If you just unmute yourself, Gerald, and let's be quick.
Hi, good evening. Can you hear me?
Yes.
Brilliant. Thank you very much. Firstly, I just want to say thank you for the organizers of this program. It's a very, very, very good initiative, bringing people from the MDT together, which is something that you hardly see in a lot of systems. My name is Gerald. I am a doctor and I'm also a podiatrist in the UK. At the moment, I'm currently undergoing the surgical training for foot and ankle. I've heard about all the comments that have been made, although I joined halfway, so I got a fair bit of it. So I'd like to acknowledge the person that talked about the nutrition aspect of managing wound. It's something that a lot of people don't look into. So it's it's a very welcome idea. It's something as practitioners, I mean, I've seen patients with diabetic foot wounds, and I can tell you that 60% of the times I don't really ask them about their nutrition. So
Gerald.
all this is about that health promotion in doing our work.
Hello. Yeah, you cut off for a few seconds there. Carry on.
Okay, can you hear me now?
Yes.
Sorry, I've got a cold, so my voice is a bit rough. Sorry. Can you hear me now?
Yes, we can.
Yes. So without wasting much of your time, what I would just like to add is about podiatry. As we're considering wound healing in patients, I think an area that hasn't been really looked at is podiatry biomechanics. A lot of us, some of us understand what podiatrists do, but a lot of us actually still don't, especially in the healthcare sector in Nigeria. I think recently we visited Nigeria and we sort of did a charity event somewhere in Surulere under Jinta Veins Diabetes Food Foundation, and then we kind of like saw patients, and most of the things that we realized that we can link the biomechanical function of these patients to foot ulceration and delayed healing. But it's an area that I'm just bringing it up as clinicians. We should start looking into it. I'm very much involved in the biomechanical aspect of podiatry and of wound healing. Can you still hear me, guys?
Yes.
Yes. So for some of us that have never really heard about this before, so it's about assessing the patient's foot function during gait and how they exert pressure on certain areas. As we know, diabetes, not just diabetes, things like rheumatoid arthritis, which can be one of the comorbidities that can exist in patients with diabetes, because we're talking about holistic care. So some of those that have diabetes might have rheumatoid arthritis, some of them can have osteoarthritis as well. So it's about looking at the foot function of this person, doing a proper gait analysis and saying where they exert pressure more, so we can apply the proper offloading techniques to be able to relieve this area. I mean, we can put the most amazing dressings on there. They can eat the best foods, to help with their nutrition. But if they keep walking on that area of peak pressure, it will delay healing and it could also stop the healing process. So I think it's an area that has to be looked at. And one quick aspect of that is the use of orthotics and bespoke insoles that can go into the patient's footwear to take away the pressure from these areas. It also involves using like a gait camera to watch the patient walk, analyze the gait, looking at things like leg discrepancy as well. Lastly, patients that have diabetes in the long run, some of them develop lesser toe deformity because of the changes in the collagen fibers. You start getting this kind of like dorsiflexion of the toes and hammer toes, claw toes and the rest of that, leading to ulceration on the apex of the toes. But with proper biomechanical analysis, we can prevent these patients from, getting ulcerations on that aspect. So we don't get to start dealing with the wound. We're dealing with, stopping that from happening in the first place, and thereby prolonging the patient's life and reducing the risk of amputation. Thank you.
Thank you so much, Dr. Gerald. That was very informative. Dr. Irere, did you want to say something? Did you want to make a comment? You can put up your hand, but we can go to Pastor Liz now. Liz Emmanuel, please.
Okay, thank you very much. I just want to ask a question with regards to listening to those people who are suffering psychological pain and when they have their wound. Definitely, that is very important aspect to look after. I was just thinking of collaboration with UK. Is there any collaboration at all? Because I realized that there is Medical Association of Nigerians across Great Britain, and I want to know if their partnership involves and can actually aid those people that are suffering from wound pain, either psychological one, emotional one, or whatever. Do we have anything of such in place at the moment?
Okay, I'll ask Olabode to answer that. Or if anyone else wants to answer that. If there is any such collaboration going on that we're not aware of, or if anyone else knows. I think he's dropped off. Okay. I think that is something we'll have to look into.
Yeah.
Yeah, and get back to you. So your question is there any kind of collaboration in terms of psychological help to
Yeah,
patients who are suffering from wounds?
that's right.
Okay. I'm inclined to say no at the moment, but I will look into that.
Right. Good.
Yeah, thank you very much.
You're welcome.
All righty. So, for those who are new here, again, I think I mentioned it earlier. My name is Flora Coker, and I'm the founder and visionary of Encapsulate Healthcare Solutions. This program, Heal the Wounds, is directed specifically for healthcare professionals. Before COVID, it was a face-to-face event. So hopefully from next year, we'll return to face-to-face events. And the program Heal the Wounds is to, as we've mentioned and has been suggested, to equip the healthcare professionals to continuously develop their skills in the area of wound management. And as we've discussed and mentioned several times today, it's not just about the physical wound, it's looking at the other aspects of what happens when somebody has a wound and all the different types of wound. I know there was a theme with certain types of wounds coming up, but it's all different types of wounds. And you have given me a lot more work to do, which is fine. This is the vision that God has placed on my heart. I am definitely running with it, but of course, everybody needs help with the vision, and together we will do it. I believe strongly in collaboration. And one of our strongest partners is Victory Drugs in Festac, which of course is run and owned by pharmacist Folashade Lawal. So I am mentioning her because she's of great help. And also my other great partner, she will not like me saying this, is Dr. Irere, consultant dermatologist. So I thank them greatly. I also have so many other people who are helping me. Bumi, Ikwama, there's so many people. My mom is on here, but everyone who's attended also, without you, we couldn't run it. We would just be talking to ourselves. But thank you so much for everyone for contributing, for making it interactive, which is what I love. And we will see you soon. If you would like the recording, if you would like the slides, please send an email to encapsulatehealth@gmail.com. And if you haven't dropped your contacts in the chat, please do, so we can collaborate, we can connect, and which will lead to innovation and better care for our patients. And with that, we'll say it's a wrap, and have a good evening. Thank you so much, everybody. Good night.